you're getting the 60 milligram dimicron MR dose, which is great. I told them in Paris 10 years ago, more than that they should bring this out as a 60 milligram tablet, and they had trouble getting the breaking right. So we have had this in Australia for some time now, and this means it would be a half to 2 tablets of the new dimicron MR tablet, and that was compared to glimepiride in a variable dose of 1 to 6 milligrams. Now, the rate of... first of all, in terms of efficacy, you can see that really both drugs are they're identical, aren't they, really? 8.4 down to 7.2 with glyclazide, 8.2 down to 7.2 with glimepiride. So efficacy of these two agents, very, very similar. Hypoglycemia rates, substantially different, with 3.7% for dimicron MR, 8.9%. So about 2.5 times as high in the glimepiride group. And if you look at patients with renal impairment, of which you have a lot here in Malaysia, we can see that the difference is accentuated with 12.6% in the glimepiride versus 2.9% in the dimicron group. So this is a really quite a substantial difference between these two drugs. And obviously a low rate of hypoglycemia is something that we do want to strive for. That again reflected in the advanced study, and I showed you the rates, but if you look at the rates of hypoglycemia in the intensive groups, you can see in ACCORD it was 10.5%, VADT 12% per year, which was very high, ADVANCE 2.7% over the study overall, so about 0.4 or 0.5% per year. So ADVANCE, much lower hypoglycemia rate than either of those two studies, at least in part related to this effect of glycoside MR to have the low rates of hypoglycemia. Now, just finally to briefly discuss the vascular effects, and I think Mark's covered this already, but glycoside, again, may be different from the other agents. It has the antioxidant effects, which are not seen with other agents, including metformin. In fact, we did some studies when I was at Monash some years ago looking at LDL oxidation and different sulphonylureas and metformin, and only glycoside had any effect on inhibiting LDL oxidation in vitro. And there is that azo-bisbicyclo ring on the end of the molecule, which is different from all of the other sulphonylureas. But it has some other properties that it has been shown to improve endothelial function, decrease fibrinolytic activity, reduce Pi1, reduce platelet adhesion and aggregation. And just to show you an in vivo study of oxidative parameters, we looked at 8-isoprostane here in plasma, pre-treatment after 4 months and then after 10 months of dimicron MR treatment in 62 diabetic patients, and there was a steady decline in the oxidative parameters. So I think the antioxidant story is real, and it is something that's seen in vivo as well as in the in vitro studies. So just to summarise, good control with sulphonylureas certainly does reduce diabetes complications, and early control leads to benefits many years later. In early diabetes, sulphonylureas are just as effective as other anti-diabetic agents, including insulin, and they're well tolerated. Sulphonylureas do differ in their effects on the heart, and glycoside MR, we know, has no adverse effects on the heart and also has a low rate of hypoglycemia and lower than some of the agents which also are in the class. And glycoside MR does have antioxidant properties. It has vascular benefits independent of its blood glucose lowering effects. Thank you.
right, thank you very much. We'll open the floor for discussion. Are there any questions from the floor? Yes, please.
My name is Dr. Mohan. I'm from Bangalore. I'm a consultant in diabetes and endocrinology, and we just completed a study on twin epidemics in 9 states in India, and 2 of them we presented in Western IDF as well as American Heart Association. My question is, it's probably the right people sitting on the stage. Do you have any thoughts on residual cardiovascular risk?
Residual in
Type 2 diabetes.
In terms of lipids, or in terms of glucose, or anything?
Residual cardiovascular risk, how to reduce it in type 2 diabetes.
Okay. Yeah, I mean, look, that's an interesting problem, isn't it? There's no doubt that, we can throw a lot of drugs at people with diabetes, but they still have a substantially elevated risk, even with ACE inhibition, with statins, and with good glycemic control. So I think one of the things that's clearly a cause of residual risk in some people is low levels of HDL, possibly coupled with high triglycerides, and that can probably be reduced further at the moment with things like fenofibrate. But it may be that if some of these newer agents for increasing HDL come along, we can do a little bit better there. Mark might comment, and I think he's going to comment a bit in the Meet the Expert session about whether we should have even lower blood pressure targets, and I'd be interested in, he might also comment on some of the newer antihypertensive agents and their role in that.
I'd just say that we know there's a big gap in, as you say, and there are lots of pathways that we have not yet interrupted. The truth is we don't really know why diabetics get increased vascular disease, because we know it's partly independent of the glucose, blood pressure and lipids. There is a gap of something else. We don't know if it's certain reactive oxygen species, advanced glycated end products, suppression of inflammatory pathways that we've failed to block. I think there's plenty of work to do. We haven't cured the problem. There's no question about it. I think the other thing, we underestimate how important underlying renal disease is, because we know in type 1 diabetes, where we don't have all these confounding other risk factors, that if you're a type 1 diabetic and you don't get renal disease, you actually have a normal lifespan. So we know that there is something about subtle renal injury that we have not yet addressed that we need to treat. So I think there's a gap, and it's a gap in knowledge primarily.
Question for Professor Cooper. How low can we bring the blood pressure in diabetes? The recent ACCORD data on the BP arm has shown that if we bring the blood pressure to systolic 120 and below, there are extra mortality. Okay. So people like Professor Cruikshank still believe strongly in this J curve, and 2 months ago when I spoke to him in Kuala Lumpur, he thinks that the elderly, we should not bring the blood pressure too low, and especially those who has coronary artery disease. And most of the elderly diabetes, they have atherosclerosis. I suppose they will have some form of CAD.
So I think there's no question, there's a theoretical reason if someone's got cardiovascular disease with a critical stenosis, that if you lower their blood pressure too low, you're going to do them a lot of harm. And there's no question you've got to be a bit careful about who you lower blood pressure very low. We know about the same with renal disease. But I think, and I will talk about this, I think in the Meet the Expert session, I think there's been a total overreaction by the ACCORD investigators to interpretation of their data. There is no evidence that there was increased death in that group. Their data are actually identical to all the other studies. It's a completely underpowered study, and they all forget that they reduced stroke by 50%, and most of us would view that as a benefit. So I think, and I will talk about the Meet the Expert, they've now done further analyses. The ACCORD study does not, in the blood pressure arm, does not sit differently with the rest of the data. It's known when you lower blood pressure much lower, the benefit you're going to see is quite modest because you've already got a much lower rate of events. But the findings that they had were consistent with what would be predicted. It was just totally underpowered. You've got to remember that the Accord blood pressure arm, unlike Advance, was less than half the number of patients. So they had inadequate power to detect what they expected. For some reason, they thought that lowering blood pressure when you're already low to even lower would have over a 20% benefit. And we know that from the epidemiology, at most it was going to be 10 or 12%, which is the number that they got. So I think this is a very dangerous message that they're sending. First of all, we can't even get down to those blood pressures in most of the patients. But if that message comes out that lowering blood pressure in diabetics is not particularly good, we're going to kill a lot of people with strokes and heart attacks who are running at the higher level of that curve.
And I think it would be fair to say that the debate about the J-curve in hypertension is just as intense today as it was a few years ago. I think that there's... I think people like the guy that you alluded to that are coming out saying we shouldn't lower blood pressures too much are almost certainly wrong. Almost certainly wrong. I mean, this, you know, in Advance, there was no evidence that people with low blood pressures did worse. In fact, they did just as well by having their blood pressure lowered as people with higher blood pressures. I think it's nonsense. I mean, epidemiologically, you can look at different populations, and always the group with the lowest blood pressure have increased mortality. But it's probably not because the blood pressure was pushed down. It's because they're sick.
Yeah, well, a lot of them
they've got heart failure and all that.
Yeah, the other thing is that there is the Harvard study where they've used, although it's not a diabetes study, where they've taken people over 80 and given them an extract, I think it was it was brindapamide, and even in people over 80, they saw over a 30% reduction in mortality. So I think it's a really dangerous message. Maybe in some people who have life-threatening ischemia or renal impairment, or they've had a myocardial infarct with cardiac failure, it would be understandable to avoid pushing blood pressure lowering too far. But in the average person with type 2 diabetes who has the risk factors but is not particularly ill, I think you're doing them harm to leave their blood pressures at 140, 150. I really do. And I think it's a terrible message, and I think it's just the Accord investigators are trying to justify glucose lowering, blood pressure lowering, and lipid lowering in all of their 3 studies. They've got no positive effects because they just didn't do it the right way. And I can say it here, I can't say it in the US, but I just don't get it, to be honest. They've done very atypical management. They've gone well beyond what we would have predicted. And so, lo and behold, they didn't get the results they wanted. And they've got to justify all the money that NIH spent on a study.
Okay, Dr. Fu. Dr. Fu is from Kuala Lumpur.
Hi, I would like you to comment about in the increase in cardiovascular event and death in those patients in advance who have a history of severe hypoglycemia, which is consistent with the VADT sub-analysis. I mean, there's some argument about whether this is a direct effect, what is association. I would like to have your thoughts on this.
Okay, so well, I would just say that firstly, you cannot determine the cause. These are clinical trials. This is not a mechanistic study. There is no question all 3 trials show that people with hypoglycemia, more of them died. Why, we don't know. Could be, you know, even if you correct for baseline characteristics, because hypoglycemia tends to occur in older people and people with renal disease and people with more advanced disease. There is a lot of data from a preclinical and even clinical data that hypoglycemia activates the sympathetic nervous system and activates a whole lot of hemorheological parameters. All of these are very reasonable explanations, but they are just speculations. It is likely that the increased platelet aggregability and turning on the sympathetic nervous system will be associated with death, but it's only speculation. A study like Advance cannot directly answer that question.
I guess, I mean, it is tempting to think that the hypoglycemia is the cause of the problem because of all those various nasty things that hypoglycemia does. Of course, the only problem with that is in the studies, sometimes the hypoglycemic episode that was recorded may have been months or even a year or more before the death. And in fact, the conclusion that Sophie Zongas has made really from her analysis is that it may simply be that people that are prone to hypos are sick. And just as if we talk about the blood pressure thing, the people that have the lowest blood pressures happen to be the sickest patients. It may be those that have hypoglycemia are also the sickest patients, and therefore hypoglycemia is like a marker. I think having said that, we still want to try as much as we can to avoid causing hypoglycemia. But whether it is actually the cause or simply an association with this increased mortality, as we can't tell from the design of these studies, and I guess we're never going to do a randomised one to find out.
Probably I can ask a question. You've pointed clearly from the UK PDS data that the rate of decline of glycemic control is almost similar whatever monotherapy you use. And that's a study done in newly diagnosed patients head-to-head. There was another study in newly diagnosed patients head-to-head trial, the ADOPT trial. And probably after that, then people sort of lost confidence in sulphonylurea and even gained more confidence in metformin. Would you like to comment about the difference in the sort of rate of decline in that study compared to the UK PDS?
I mean, when you look at the HOMA analysis in ADOPT, there's no doubt that it, initially was the highest and then had the most rapid fall. When you look at the last couple of years of ADOPT, in fact, the slopes look extraordinarily similar for the rate of beta cell decline in those studies. And whilst I think there was, I guess, a suggestion that rosiglitazone might have been a bit, did retard the decline in, well, whether it's a decline in beta cell function or certainly it retarded the need to go onto other treatments and insulin. For the first 2 or 3 years, better than the other drugs. One got the impression, I guess, by the 5 years that things were really starting to come together. Had it gone for 10 years, who knows what we might have shown. So I think we would love, I mean, we're all desperate to find a drug that's going to really stop beta cell decline. I mean, there's been great hope with the GLP-1 analogues, and in animal studies they do seem to have some beta cell predictive properties, but I guess to date we don't really have evidence in humans that that's the case. And I mean, maybe we will when we see longer term studies with the injectable agents, but I think at the moment we're still really struggling to find anything that modifies this process, unfortunately.
So that means it's fair to say that SU would still be a good first line option in a newly diagnosed diabetic? Well, I think it is, and I mean, and I was asked to give this talk and had to review all the data on sulphonylureas, and I think like many physicians have sort of come round to thinking that the newer agents are better and that we should be jumping in this. And really, when you look at the evidence, there isn't really evidence that the newer agents are better. There are obviously additional things that we can use. Look, in the very overweight patient, I mean, there may certainly be advantages in using GLP-1 inhibition and going along those lines. But they're very, very expensive compared to sulphonylureas are cheap. And I think until we have no long-term safety data whatsoever on any of them. And so I think certainly as far as the sulphonylurea arm goes, I think the ADA EASD guidelines are absolutely spot on. It still really is second line. The only thing I take issue to in those guidelines is the early use of insulin. Not that it's we know from UK BDS it's just as good, but I don't see why you should subject a patient to insulin when they could take a tablet. It doesn't really seem logical to me. So there's certainly a lot more cost involved, particularly with the long-acting insulin analogues that tend to be used these days. A lot more cost than using a sulphonylurea, and there doesn't seem to be any benefit. So insulin's a great drug when patients need it, but I don't see why it should be used early. Our local Malaysian diabetes guidelines published last year, we felt that we were not going to be specifically indicating a specific drug for the first line. So what we advocated is monotherapy, but it would depend on the physician to decide which monotherapy depending on the phenotype or the glycemic pattern, and I think that's probably where we're directed. Any more questions from the floor? Just a last question, Professor O'Brien, is that I work in the public hospital, and where I work, the only two SUs available are either gliclazide or glibenclamide. So my trend in the last few years is to use gliclazide because of the concern of hypoglycemia, because there's so many elderly people still coming in with bad hypos on glibenclamide. But out there in private care in Malaysia, there's a whole host of different SUs to pick from, and I think there is still a substantial use of the others that probably you have indicated may not have such a positive effect. Is it fair to say that maybe we should indicate preferred sulphonylureas?
Well, I think that's, it's difficult, but I think that you should certainly recommend sulphonylureas that don't adversely affect the heart. So glibenclamide should never be used.
Yeah, I was wondering whether we should just take it away.
You've got better drugs now,
yes.
It has quite a high rate of hypoglycemia. Yeah. It has adverse effects on cardiac muscle. Although, having said that, we do have evidence, good evidence in UK PDS that it was effective. Glimepiride, I don't know if we've got any long-term trial evidence with glimepiride. We certainly don't have an advanced type study. You do have good evidence from a big study with gliclazide. I think you need to use one that's not going to have adverse effects on the heart and has the lowest rate of hypoglycemia. And certainly the guide, I mean, it was a smaller, it was 400 or 500 or 600 people, but nevertheless, it did suggest that gliclazide was different from glimepiride, which is the other drug that doesn't adversely affect the heart, and therefore I think it is useful. And as I mentioned, that is incorporated actually into the NICE guidelines now, where they do say that there is evidence that the hypo rates are different.
Okay. All right. I think we've had an interesting discussion, and we'll call it a close. Thank you very much for your participation, and thank you to the speakers.
And on examination, he had a normal body mass